Welcome everyone to this session. If we can switch to the other laptop, please. I'm Michael Hofman. I think I know most people in the audience. I'll do a quick intro of the panel. This is going to be like a real live MDT, focused on PSMA PET CT imaging. And if you like this session, come back tomorrow. We have one on lutetium PSMA. We have Dr. James Buteau, who's a PhD student in nuclear medicine physician with us. Professor Ting Lee from the Austin, who's head of our Australasian Nuclear Medicine Society, Professor Louise Emmett from Sydney, who needs no introduction, nuclear medicine physician extraordinaire. Dr. Sidney Levy, who's a dual-trained radiologist, nuclear medicine specialist from Peter Mac. Dr. Tang, who was one of our previous fellows, but is now a senior consultant and associate professor at Singapore General Hospital. George Hruby, associate professor from Royal North Shore, who's going to give us some radiation oncology toilet bowl insights. Professor Dan Moon, who's a urologist at Peter Mac and Cabrini. And right at the end, like a real-world MDT, there's always a last-minute apology. So Dr. Sandhu sent her apologies. And we have Dr. Louise Costos, who's one of our medical oncology PhD students and PCF young investigator. So let's kick off. Myself and Ting are going to introduce alternate cases, and then James will show us the cases live using our MIM imaging software. And we do have some audience votes, so if you haven't scanned that QR code, please do it now, or you can just go to slido.com and enter that number.
So case number one, as you guys can see, is a 72-year-old chap with a PSA of 8.7. The DRE MRI results are there, and the prostate biopsy showed a grade group 4 lesion. So firstly, James, can we have a look at the PSMA PET CT, and then we'll throw it across to one of our panelists to see what we do next.
Yeah, thank you. So you can see the MIP of this patient to the left, really dark windowing. This is how we had the images that were imported externally. You do see down here the prostate cancer with high uptake. I don't know, I think the windowing is an important key when we review them in MDTs. We really change this. So this is over-windowed, higher threshold of 5. We generally read them at 15 like this. As you can see, and it standardizes it. So you can see the right posterior peripheral zone right here has a mild focus of uptake, ACV max of 5.4. It's quite limited in extent. And then there were 4 metastases described in the bones. You can see one up here. So if you kind of over-window it like that, you can see them standing out. One in the right humerus, one up here in the inner rib. There's a sternum lesion right here. And when you have a close look, you don't actually see any lesions on the... You don't see any osteoblastic lesions underlying, some little soft tissue abnormalities. And I think the most interesting thing is that there's this kind of tubular uptake in the right flank. When you have a closer look, there's actually this thickening of the distal bowel, which is quite prominent. Many little nodes as well, mesenteric nodes, a much larger one right over here, that don't have very much uptake, but raises suspicion.
Like that wasn't a hint there, James. But I might actually hand it over to one of our panelists, perhaps one of our nuclear medicine experts.
Could we
might just do a vote first.
Oh,
Can we switch back to the other laptop? Yeah, there's a vote. Oh. And when we say are there bone metastases, we mean from prostate cancer.
Can I qualify
bone
something,
metastases
James,
from...
You've got a high-grade cancer with what seems a relatively low SUV. Is there any role for an FDG PET? I mean, would you be concerned that you're missing something here because...
Yep. Yeah, we'll get to that in a minute, but we will probably just do this vote first, if you don't mind, Dan, sorry. But that is a very good thought, in fact.
But this is quite a typical scenario. This was an external PSMA PET confidently reporting multiple bone metastases, comes to the MDT, we review it, including the low-dose CT component, which is very important, and we see something that doesn't quite add up.
Good.
So we've got a bit of a split in the voting. We've got equivocal, probably benign, probable bone metastases 30-30. This is always good. We know we've come up with good questions when we can split such a large audience.
In thirds? You literally have a split in thirds?
Yeah, we prepared very carefully.
Oh, okay.
Fantastic.
When
I'm
we get to
pleased.
100, we'll close the voting. So, the next best step, and anyone from the panel can really answer. Dan has already put in a vote that he'd like to have something else. But what would be the next best step?
What would we biopsy if we were going to do a biopsy? Biopsy one of these tiny bone lesions. Sydney, do you think that's a feasible thing to do from a radiology perspective?
I don't know if there were any abnormalities in the...
None on the CT.
Speaking to a thing.
I don't know if there were any abnormalities in the inguinal, axillary or cervical regions, but certainly would love to biopsy something, but preferably not the mesentery. Yeah, I think this patient will eventually get a biopsy. Just need to have a look at the whole study, but definitely...
Sid, you'd get an FDG before a biopsy, come on.
Yeah,
Come on.
you'd get an FDG.
Yeah, so we did an FDG. In fact, we followed, that was the conclusion of the Peter Mac MDT was let's do an FDG. So we did one. If we can switch back to the other laptop, we'll see the FDG performed a few days later. You can see we were able to do it in a timely fashion, 11th of July. What does it show?
Yes, you can see there, it's a good question. So there actually weren't any enlarged nodes in any accessible regions. You can see on the FDG there's scattered multiple bone, highly FDG avid lesions. You do see that bowel was highly FDG avid. It's a little displaced here, but very intense uptake as the mesenteric nodes, this chunkier one here. And you do see in the right paracolic gutter, there's also some peritoneal involvement right here. Going up and around the liver, and then some other nodes. So what do we do next?
I think we better do a biopsy now, but at least the FDG, there's lots of spots for Sidney to stick a needle into now. I don't think he'll find it too troubling to find something.
What should we biopsy?
I'll probably, at this point, be having a chat to our haematology colleagues and doing a bone marrow. Yeah, so maybe if we can have a look at the pelvis. Yeah, there's some spots.
James,
there.
what did the biopsy show?
Yes, the biopsy revealed actually we withhold that he had CLL, so he was known for CLL, and he did have high-grade transformation. So it was unrelated.
Great.
Clinical information.
Yeah, we might switch back to the other laptop. So I think a teaching point from this case is when you see faint uptake in bone, it's not always metastatic disease. If your SUV is 20 in bone, you're done and dusted. It's prostate cancer metastases. But when you see this faint uptake that you really need to wind up to see, just think twice. One, could it be benign? Two, could it be something else? Another teaching point is to look at the low-dose CT carefully. We would tell everyone to use a standardised reporting system. At Peter Mac, we currently use the ePSMA system predominantly. This is because Ken is the senior author on the study. We'll probably switch to the SPARC guidelines when they come out. But this would, fit into this sort of equivocal zone, faint uptake in a site typical for prostate cancer or intense uptake in a site atypical. I think it would fall into that, and then you think about what to do.
I've got a question for the panel and even some of the audience, actually. Who uses the ePSMA guidelines in the audience? Okay, Peter Mac, and where are you from? Philippines. Thank you. Welcome.
Ken put his hand
Oh,
up.
and Ken, of course. All right. Louise, what do you use?
So we use mainly Promise version 2.
Okay. Anybody in the audience use Promise version 2? Ken does as well.
But planning to move to Spark when it's available.
Fantastic. So for those who didn't come earlier, watch this space for Spark. Okay, we better...
Can you put your hand up twice? I'm a bit concerned. Do you do 2 PET reports for each scan? Case 2. So this is a 68-year-old patient with a PSA of 7.6, PIRADS 4 lesion. Biopsy shows a 4 + 3 = 7, which is a grade group 3, so a clinically significant intermediate to high-risk prostate cancer. And we were asked to review an external PSMA PET CT, which reported a possible metastasis in C4 vertebral body.
So you can see the PET scan here. There is a high avid focus in the transition zone. So primary score 3, SUV max of 10, and you don't see any nodes with uptake. The only other abnormality that stands out is really just that C4 lesion. As you can have a look, it's near the superior end plate, very highly avid, SUV max of 14. It's really isolated, and we don't see anything on the low-dose CTs. We can have a closer look. We don't see anything convincing on
Can you mag that up, James? It's nice and...
Oh, yeah.
Yep.
Forgot we have a radiologist in the room now.
Yeah, okay. Yep.
What do you think about that, Sidney?
Hemangioma.
Why do you say that?
Because you can see that there is a subtle lesion there, and I would want to know more about. Actually, I think we have the introduction, but it wasn't a particularly high risk cancer. There wasn't anything in the pelvis. There wasn't anything anywhere else, and I can see a lesion on the bone scan that doesn't look on the CT that doesn't look particularly aggressive. Sometimes, if you're lucky, you'll see the coarsen trabeculation. And you'll see the features that are typical of a hemangioma.
So in this case, how do you actually know it's a hemangioma? Say you want, because it's a really big core.
So if you can't diagnose it on the CT, i.e. you can't see the typical CT features, you have one other tool you can use, and that's an MRI, and the MRI will show the presence of fat within the lesion, and that can be helpful. It has a very high negative predictive value for metastasis if you see fat within a lesion on MRI.
If we can switch back to the other laptop, I think the question for the MDT was, this was reported as a single bone metastasis. It's got an SUV of 14. It really stands out. It's not in the equivocal range. It's not low. This is really intense uptake, but there's a single lesion. Dan, as the treating urologist, hypothetically, would you be... What would you do next?
This is where the communication and the MDTs is so important. This has happened to me multiple times where I've seen really absolutely unequivocally called bony mets. Someone who had multiple up and down the spine, and it looks for all the world like to a urologist, simple urologist, as metastatic disease. And only an MDT will clarify that. Sometimes we're lucky it's in the pelvis, and you can look back at the MRI they've had, and you see the bony windows on that, and that clinches it. But without this discussion, we don't have the benefit of that diagnosis.
So would you want additional tests, or would you just proceed with curative intent surgery based on...
Proceed to curative intent treatment.
Yeah. So I think at this MDT we elected to do a MRI since there wasn't really a definitive finding on the CT. I think hemangioma was suspected based on some very subtle findings on the CT. So an MRI was done.
Yeah, just have, you can see clearly, I mean, this is 101 MR, but to the left you see it's hypointense on T1. You have a little bit of hyperintensity in the middle on T2, and then it does enhance on contrast. So it doesn't seem to be very high, like high fat containing. I don't know if you have any thoughts, Sid?
So that's not diagnostic of hemangioma on the images that you've shown.
Yeah.
So that creates some more doubt.
Yeah.
Unfortunately, hemangiomas do also look like that.
Yeah.
But, as I said, the key thing's that negative predictive value. If you've got the fat, then that's really helpful. If you don't, you have to make absolutely sure the patient hasn't had any other imaging anywhere else in the last 5 years, and try and establish that it hasn't changed over time.
Yeah. Sounds good. So this patient actually had a CT done, diagnostic CT, and very classic appearance. So it was more of an atypical low-fat containing hemangioma, and he went on to get radical prostatectomy with undetectable PSA. Well
Sidney,
done.
I just wanted to add as well, I think from our point of view, biopsy is really important because we've had 2 cases recently, similar situation where there's been an isolated PSMA avid bone lesion, and on biopsy one of them ended up being a plasmacytoma and the patient was found to have myeloma. And the other one was very interesting. It was PSMA and FDG avid in a patient with a history of localised melanoma, and it ended up being melanoma. So is there any way to differentiate the etiology on CT and PSMA PET, or in those situations is biopsy really needed?
Sometimes with melanoma there are particular features in MRI that can help, but unfortunately the most helpful thing is old imaging and the fact that it hasn't changed over time. And if you don't, MRI's main role is ruling in benign lesions, and as soon as you don't have the features of a benign lesion, such as that scan, you're a little bit stuck, and sometimes you do need to biopsy.
What about the cases, this is sometimes thrown up where biopsy is technically pretty difficult, and it's a really line ball call of giving 3 months of androgen deprivation and rescanning and seeing if there's been a response. What are the thoughts on that?
We do that a bit when it's quite difficult. But the other question I've got for you, Dan, so they've got one small lesion, it's potentially metastatic, it's equivocal, we're not too sure. The MRI was inconclusive. Would you give them the benefit of the doubt and go ahead and give them surgery?
More than that. I've also often had off-license stereotactic radiation to wipe out the bony met regardless, so we treat them both, and we never know what we treated sometimes, but it was...
I want to caution that approach because I've actually, this is actually quite an unusual scan because the focal intensity of uptake is super high. You can call it a metastasis easily. I've seen a hemangioma like this get stereotactic radiotherapy because it was a presumed metastasis, but the PSA didn't change at all. And then in FDG was done and metastases were seen elsewhere. But I think my key message is actually most bone metastases from other causes have really low intensity uptake. This is actually very unusual to have SUVs of 15 or higher that are really focal, and the main differential there is a hemangioma like we just saw. And the key here is that there's a single one in a patient with an intermediate risk prostate cancer. So when you add that pre-test probability, you're a little bit less certain, and then you do the MR and maybe a biopsy.
Just one other point that can be helpful, for pelvic bone lesions, if the patient's had an MRI prostate with a diffusion sequence, some data, not particularly robust data, but data nevertheless suggests that there's more than 90% agreement between positive DWI and positive PSMA PET CT for metastasis, as opposed to degenerative geodes, which is actually often the most common thing. So in the pelvis, if it's subchondral, if it's up against the joint, you should be saying, why isn't this a degenerative geode? If it's not up against the joint, then unfortunately, if you have an MR, it's worth having a look, and it may help.
The other person involved in this discussion, by the way, is the patient, who also needs to be very much brought into the negotiation here, because there's definite harm from undertreating or delaying treatment as significant malignancy on a whim where we're not sure what's going on elsewhere. So they have to understand the risks involved on both sides and help make a decision as to how they'd like to proceed.
Yeah, I mean, benefit of the doubt is so important, and it's a lovely case where you go radical P. If the PSA hasn't dropped to 0, then hammer it with SBRT. But I would do that sequentially. I wouldn't do it at the same time. I'd wait for Dan to operate first and watch the PSA kinetics.
See, Ting, we might move on to the next case. I'm going to push everyone along for time.
Yeah, I think so. Right. Next case, a 51-year-old chap recently diagnosed with a PSA of 24, Gleason score of 4+3 equals 7, grade group 3, and we're now looking at local definitive treatment. Can we have a look at the bone scan first?
Yeah, no, that's good, that's good.
Ooh, it's
It's
a bit
the bone
blurry.
scan, is it? Is it? I don't, yeah, well, I heard Declan, is he in the room today or no?
They all look
It's
like-
normal. He was describing bone scans as blurry little smudges all over. I think here we can clearly see now.
This is taking it to that next level of challenging when it comes to interpreting bone scans, despite the presence of a SPECT CT. So would you like to tell us what it should have shown? Oh, well, here we go.
A little crisper now. So you do see 3 mild sites of uptake. On the planar, a little hard to make them all out. You can see them a little bit better on the SPECT CT. And he did have a PET scan. So you can see the PET scan here, PSMA PET, extensive, highly avid, 20 to 30 bone metastases, very intense primary. See with little asterisks down there. So it's much clearer. I think we've seen a few interesting cases this morning like this.
So, question for the panel. Are bone scans still useful clinically? George or Louise, would you like to comment?
Why are you asking me? I haven't seen a bone scan for 9 years.
Okay, well...
And I'm not a medical oncologist, so it doesn't affect my practice.
Louise Costos might be a bit young, actually, to even see a bone scan.
Certainly for us, I mean, particularly at Peter Mac, we obviously see a lot of PSMA PET scans. I think in this, the difficulty we have is most of the practice-changing trials that the drug approvals are based on used conventional imaging. In saying that, we do use PET scans. So in this situation with that PSMA PET result, as long as it's been reviewed in MDT and thought to be windowed appropriately and definitely metastatic disease, we would treat based on that. So if I saw that patient in clinic, I'd be discussing systemic treatment, at the very least doublet therapy with a novel hormonal agent and androgen deprivation therapy, and depending on the distribution of disease and the patient fitness, possibly even triplet therapy as well. My understanding was bone scans really come into play when we think about radiotherapy to the prostate. Do you use them then?
No.
No.
But in this case, you would irradiate the primary based on conventional imaging of stuff that, I think it's just an out-of-date scan. I say there's no evidence, but we don't use them at North Shore.
So question for Louise. Are you going to put this patient on ARPI? Are you going to add docetaxel? You're not going to add docetaxel? How do you make that decision within the confines of trying to make this jump? You just assume it's high volume.
Yeah, I think looking at the scan, it definitely looks high volume. The question is the distribution, because when we look at the trials evaluating triplet therapy, which is docetaxel, and ARPI and ADT, the benefit was most clear in those who had de novo metastatic prostate cancer as opposed to recurrence, so in this case, but also those who had visceral metastases. So if there were hepatic or pulmonary lesions on that PET, I'd definitely be leaning towards triplet therapy. If the patient was very fit and young, otherwise I think it's still worth a discussion, but the benefit's less clear with adding docetaxel.
And me being nasty here, so you've said they're high volume, so you're not going to irradiate their primary?
That's a question for the panel.
So there's good evidence to irradiate the primary here, because that's all based on conventional imaging.
Yeah.
Yeah, so this is the evidence, and it comes from the Stampede trial, published some time ago. And what it showed is that there were two groups of patients defined by bone scanning predominantly. Those with small volume or low volume disease that had a survival benefit, an overall survival benefit when radiation of the prostate bed was added to systemic treatment, whereas in the high volume disease, there was no survival benefit. I've actually questioned this study. I've written an editorial on it. I think there is a confounder, which is that the bone scans had a lot of false positive results. I actually believe that the patients with 3 or less bone metastases had a significant amount of M0 disease where there was no metastases and they were just calling fractures and benign things, and that's why there's a difference in OS. But that's quite a controversial point of view. Most people accept this evidence base.
I think, Michael, that is controversial. What's really interesting is when you re-PET these guys at, say, 3 to 6 months after very heavy systemic treatment, there is still uptake in the primary. So you can see why there might be a benefit to some local radiation by taking out the evil clonogens that are lurking in the mothership.
Shall we move on to case 4?
54-year-old
who's after a radical prostatectomy for Gleason 9, grade group 5, positive margins, PSA is 22. Conventional imaging shows no metastases. After the operation, the PSA drops, but to 2.5. The question is, first question for the audience, do we need anything? Should we just, standard of care before PSMA PET would be raised PSA post-surgery, there's residual disease, irradiate the prostate bed. Should we proceed to salvage radiation, yes or no? George, I don't think there are too many radiation oncologists in the audience, so I'm pretty impressed that 70% of people would do radiation. So you've done a good job educating everyone.
Goodness. I should be in advertising. Sorry, Michael, two things. What was the time interval? Well, firstly, why did he have a radical P with such a high-risk cancer? And number two, when was the PSA 2.5? Was it a week after surgery or a year after surgery? 'Cause
3 months.
Okay, 3 months. So, yeah, it's a worry.
Yeah, it's persistent. So it's definitive persistence. It's been repeated twice and it is elevated. Now, George, would you like to give radiation in line with the audience vote?
I would, but he's not going to do particularly well because you saw from at least 3 presentations this morning that PSA is relatively high, probably got micrometastases, and so I would be treating fossa plus nodes plus ADT in this situation.
So you would not do a PSMA PET?
Oh, I would. Of course I would.
Oh, you would?
Sorry.
Okay. Yeah, so I think this is a patient who didn't have PSMA PET as part of his staging. He was probably in that. Most patients today would in Australia, but globally, many of these patients still don't. So you would do a PSMA PET before.
Okay, so let me go back a step. I'm so sorry. So yes, I would do a PSMA PET before thinking about radiation and all those options I gave you.
It's because his conventional imaging is PSMA PET, so you have conventional
misunderstood the
imaging.
question.
It's not novel anymore. Well, I think it's a good decision. You can see the extensive, you see there's that sign he has had radical prostatectomy. You do see extensive nodal metastases throughout the retroperitoneum, iliac chains. Up here there's a nice retrocrural one, even up in paraspinal, upper cervical. You can see most of them, interestingly, are actually very small. Below 1 centimeter, so nothing stands out. I think if repeat conventional imaging was done, just for the thought process, I think the PSMA PET actually reveals quite a bit.
Yeah, it's quite a striking difference between the CT here, which has just tiny nodes, and the PSMA PET. George, would this change your management?
Oh, absolutely. I'm so glad I changed my mind. I've spared this patient a truckload of toxicity. He needs to go to Louise Costos for some life-preserving or life-delaying treatment.
It just shows how hopelessly inadequate conventional imaging is, and we see this all the time. It's just there's no situation I can imagine in any developed area of Australia where this would happen now. Yet this is routine overseas. I think you're running blind. You can't treat this guy without a PET scan for this reason.
I think this patient, ideally, if we look at the pro-PSMA study, they really should have had a PET scan prior to surgery, and that probably would have changed their management, I presume.
Correct. That is my next slide, in fact, Louise. You are a thought reader. This patient, should have had a PSMA PET scan at staging because he wouldn't have had a radical prostatectomy. But this still happens. There are men with high-risk prostate cancer who get operated on around the world who don't have a PSMA PET scan first, and we saw in pro-PSMA just how high the management impact was. We might go to case number 5, Ting.
Great. Next case is a 62-year-old with PSA of 6 and a PIRAS 4 lesion with a biopsy showing, again, grade 2, this time 3+4, and again referred for consideration of curative intent treatment. So firstly, can we have a look at the PSMA PETs for staging before surgery?
All right, so you can see his PET scan. The primary is very avid, so SVU max of 13.8, so primary score of 5. There aren't any pelvic nodal metastases, so go through quite carefully. Nothing is abnormal. When you come up in the upper abdomen, you do have this little nodular uptake here. I don't know about this. 0.6 by 1.2, a little chunky. Mild uptake, and then you do see some little sites of uptake here. So you don't see any bone lesions, nothing else. I think can maybe have an audience poll. What is this?
Are these nodal metastases? Yes, no, or a special category called equivocal.
It's funny you showed that because on... Oh,
Oh, there's some equivocals. This is actually the only case we've repeated from ProsTIC24, where we showed this case. And we did that to, it's actually a psychological experiment. We're looking at the difference in voting between the two meetings. Well, at that time, there were quite a few people that thought it was a nodal metastasis.
right.
And 2 years later,
Experience counts.
correct. So it seems that this
The
trap,
preceptorship is working.
correct.
Yep. All right.
Should he have had a PSMA PET in the first place? ISIP2, I wouldn't have done it. This is the problem.
Yep.
Actually, it's
And if
not
you go back
funded,
to the
is it?
very old guidelines, PSA less than 10, favourable or intermediate risk. You know, when I was a boy in Canada in 2000, we wouldn't have even staged this.
See,
We've
so
just
how
gone
did that
ahead.
happen? The government rebated ISIP2 as well as ISIP3 and...
Well, it gets called intermediate, but it's not.
Intermediate and
I
as
don't
well
do
as
it,
high
no.
intermediate.
I don't think it's the right reason.
So this was a trap early on in PSMA PET. This is actually uptake in the celiac ganglion. And when PSMA PET got introduced a decade ago, I think these were called lymph node metastases, quite confidently. And then actually some colleagues in Germany did a excisional nodal dissection and with a probe where you could find the nodes very carefully, and they cut the celiac ganglion out and confirmed PSMA expression. And we see the same phenomenon in the stellate ganglion. So this is an unusual phenomenon. Sidney, how do we differentiate these ganglions on imaging?
They usually have location is the most important thing. They sit near the celiac trunk. They're often bilateral. They're often a little bit elongated. They don't have a typical nodal morphology. They don't have a fatty hilum. They often look a little bit more rectangular or trapezoidal. And in the same study, you might see other ganglia, such as the stellate ganglion in the example that you provided. It's a nice demonstration of sympathetic trunk anatomy. Yeah, the other thing is quite commonly there'll be a little bit of uptake on the opposite side. There's two celiac ganglia, and whilst they're often asymmetric, there's usually a little bit of uptake on the other side as well. So those are some tips.
Yeah, you get pretty good at picking them on the CT, these little elongated structures. I think what I found striking is when we started noting this, when I went to my radiology colleagues at the time, like 8 years ago, no one really could see the celiac ganglions on the CT, but as a result of PSMA PET, everyone got very good at picking the celiac ganglions, and they look a little bit like the adrenal glands. And after you've seen it and it enters your brain, you kind of see them on every CT scan just about, and then if you wind up the PETs, you see it on a lot of scans as well. Case number 6, Ting.
Right. Okay. Next case, 62-year-old, PSA of 12, Pirates 5 lesion, grade group 5, on biopsy. The PSMA PET, can we have a look at that, please?
Yes. So you can see the PET scan right here. The primary is highly avid, goes from apex to base, peripheral zone, SV max of 17, so a very primary score 5. So I have good confidence. It does seem to a little irregular. I'd have high suspicion of some extracapsular extension there. Does not seem to invade the seminal vesicle. And we do have a couple of nodes there. You can see in right obturator one right here, highly avid also. It is a little under a centimeter. And on the opposite side as well, another little node right there. So there aren't any distant metastases. You do have some pelvic nodes, so N1, M0.
So we've got some questions for our MDT.
The prognostic significance of the nodal metastases on PSMA PET. Does anyone want to comment?
Yeah, I think.
Go ahead.
Sorry,
George?
Yeah, George, please. Yeah, it came up, and this is part of the long-term follow-up of the ProPSMA study. as opposed to conventional imaging, we're now realising that N1 disease on baseline PSMA PET CT staging just is associated with a higher incidence of poor oncological outcomes in the medium term.
So Dan, if you proceed to prostatectomy in this patient, would you cut all those nodes out at the same time and do an extended nodal dissection?
This is a really controversial area, Michael, and the first thing is that I would do different things in different patients here and always in conjunction with the radiation oncology colleague. So these patients will see myself, they'll see a radiation oncologist. There are a number of different options here, and it depends a bit on symptoms, local issues, age, comorbidities. I see he's 62, but someone who's very young and fit, and particularly with local symptoms, for me, is more likely to perhaps go down the path of surgery, which will include a node dissection. Someone who is, but they would get both options. Or the other options is obviously ADT and prostate and pelvic nodal radiation. I've also had cases, again, because of significant BPH and local control issues, where we've done prostatectomy and then had pelvic nodal radiation. So there are a number of different options, and it's a team approach. It's really what's going to suit that patient best.
George?
I'm sitting next to an enlightened urologist. I think patient choice is really important here, and hearing the pros and cons of both approaches from both people. If you go back to some of the early nomograms, PSA greater than 20, Gleason 9, ISUP 5, and probable T3 disease, I think you guys were talking about on the PSMA PET. Those alone, regardless of what the PSMA shows in the nodes, predict for a less than sort of 40% long-term biochemical cure from prostatectomy alone. So he has to know that. And he has to know that if he's walking into a prostatectomy, he's more likely than not to also walk into post-op RT. So you're really piling on the morbidities here, and the patient has to go into this eyes wide open. I personally am a big fan of that last option. If someone's got terribly obstructive local symptoms, then perhaps marrying up, and again, this needs to be nuanced with the patient, but RT will make those LUTs and those obstructive things worse in the short term. So either you put them on hormones and see if they improve and you can get away with radiotherapy, or someone who's young, fit, and has really terrible LUTs, surgery to the prostate alone and then radiotherapy to the nodal basin, but hope like hell they get clear margins so you don't have to treat the fossa. So these are all kind of, complex discussions, and we don't have any right answers now because there are no randomised trials in this space.
So we don't have, in a patient, let's say he doesn't have any symptoms, so you've just got those scan findings. I think it's maybe a little bit of a cop-out to say let the patient choose, because they're going to see maybe a radiation oncologist and then a surgeon, and the surgeon highlights the pros of surgery, the radiation oncologist highlights the pros of radiotherapy, and then you leave it to the poor patient who doesn't have a medical degree to decide.
No, it's not quite. I mean, for a start, the patient is a sentient human being, so they have to have a choice. And number two, I'm not saying you can either go to Dan and have a radical P or you come to me and have radiotherapy. I think you need to say, if you go down the surgical pathway, you will more likely than not also need radiation treatment, and that will often sway the patient, because they'll go, I don't want to wear two lots of morbidities, I'll stick with you, George. Now, if I was going to treat him, I'd be boosting the primary, GTV boost like the FLAME study, I'd be doing relative urethral sparing, and I'd be whacking out those nodes in my elective field.
So, George...
And I do believe that rad-onc is better at treating the nodal basin than surgery. Not better, it's the wrong word, but we know that even in extensive node dissection, surgeons don't pick up some of those funky
We're not going to get
nodes.
all the disease, we're not going to get all the nodes, we're not going to get all the lymph node channel spread. I think we do get better local control though, and that's where sometimes it is a really nice marriage of prostatectomy and nodal radiation, but it depends on the case, I guess.
I think Louise has a
We've
comment.
also got the benefit, not only sentient human being, but we've got the wife next to him saying, just get it out.
I think in these cases as well, when you've got a young fit patient with terribly high risk disease, you also have to consider, is there any way we can intensify their treatment with systemic therapies? And other than androgen deprivation therapy, there's not really anything approved at the moment, but there are clinical trials. There was the lutectomy trial that's now completed, but that was run through ProsTIC, looking at whether giving neoadjuvant lutetium PSMA has any benefit prior to a radical prostatectomy. And then there's currently another trial called Ascertain, which is looking at giving a very short 3-week course of neoadjuvant, either a novel hormonal agent or a novel PARP inhibitor or both prior to surgery, and seeing if that impacts on outcomes.
So Louise, would you want to see this sort of patient as a medical oncologist, or do you think you want them to see the radiation oncologist, urologist first and deal with it down the line?
We wouldn't routinely see these patients. Ideally, they should have a robust MDM discussion, and then if the referring doctor thinks they're appropriate for a clinical trial, then we would see them.
Yeah, just highlighting that data from the PRO-PSMA trial, which hasn't actually been published yet, but I think it's under peer review. Just looking at the 3 to 4 year follow-up of the patients with N1 versus N0 disease, and at 3 years, 75% of patients who were N0 on a PSMA PET were free of any event, of any recurrence, versus 46% if you were N1 positive on a PSMA PET. So that's quite a big difference at 3 years. Hazard ratio 2.1. This is one of the great things about doing clinical trials, is we can continue to follow up this group of 300 men and see what happens to them longer term. Undoubtedly we'll continue to follow them up and see what happens even longer. Case 7.
All right. 71-year-old man with initial PSA of 4.1, PIRATS 5, had a radical prostatectomy in 2015, grade group 2 with negative margins, presented with right upper quadrant pain, but a very low PSA of 0.01. Diagnostic CT that I think the GP did showed 2 hepatic lesions. Can we have a look at the
PSMA PET? Dan, you'll recognise this case. We may have modified the history a touch.
So you can see there's no uptake in the prostate bed, nothing in the nodes. When you go up, you actually see this very large right hepatic lesion up to 6 centimeters, very intense uptake, SU max of 29.2. It's quite heterogeneous on the CT also. It looks like quite an ill-defined heterogeneous lesion, some hypodense areas as well. And in the left lobe, you do see a second lesion, about a centimeter, SU max at roughly 9. Nothing else, nothing in the bones.
Louise, will you need to comment on this case, please?
Louise Emmett?
Oh no, Louise Emmett, PSMA PET CT perspective. So undetectable or very low PSA, Gleason score was grade group 2, but the CT shows this, which prompted a PSMA PET.
I think they've got hydatics.
Louise is voting for hydatid disease.
Would you like to comment?
I think first of all, we need to make sure that is this related to prostate cancer, or is it because it's been poorly differentiated and the PSA is not up and it's still related to prostate cancer. So I think we need to determine the etiology first.
How would you determine the etiology?
I think biopsy is a good option because the lesion is quite large.
Would anyone do anything else apart from a biopsy?
Alpha fetoprotein, and is he a boozer?
Look at the old imaging from 2015.
The radiologist wants to look at the old imaging. Do we have old imaging?
I don't know. 2015, that's quite specific. You've seen this case, yeah. yeah, that's good. You have a good 24-hour memory, yeah. So if you do look back, I think you see the FDG PET that was done in May, prior to any prostatectomy. In April 2016, in the middle of PSMA PET scan, and there was absolutely nothing there on the PET scan, nor uptake nor any lesions.
So it's new over an 8-year period. Louise, do you still think it's a hydatid cyst?
I think what everyone said is very reasonable. But yeah, I mean, hydatids can be quite positive on PSMA PET, and we have had cases before that have been written up. So, I'd like to know a little bit more. But obviously, another primary is going to be considered. It wouldn't likely be prostate cancer.
So I think the message is the best test is time, and when you see that this is new, it's definitely something that warrants further investigation. The pre-test likelihood is that this is not prostate cancer. You don't just want to put this patient on hormone treatment, definitely not. Louise Costos, what would you do here?
Yeah, I mean, it's certainly large and concerning, but also unlikely. I would have been surprised if that is prostate cancer, given that the PSA is suppressed and it's a solitary lesion. I mean, you can, in more advanced disease, if the prostate cancer differentiates, the PSA it, may become, non-secretory disease, but in a patient who's naive to any systemic treatment, that would be very unusual. So I'd be biopsying that.
Yeah, I've got to tell you, the biopsy hasn't been performed yet. This was actually a case at our MDT from last week, so we'll give you the result at ProsTIC24.
Have they had an AFP, Michael?
We did suggest an AFP at the MDT, so I don't know that that's been done. I think Louise's suggestion of a hydatid cyst is also good. This is not going to be prostate cancer, but the FDG PET doesn't show a primary elsewhere, like a colorectal primary, so it's a bit of a mystery. I would do a CEA, I would do a alpha-fetoprotein hydatid serology, and probably a biopsy. But I think the key message with the cases to date has been, if we can switch to the other screen, has been that the hard part of reporting PSMA PETs is that not everything that lights up is gold or prostate cancer. This is the same problem with FDG PET. The hardest aspect of reporting PET scans is not to report everything that lights up as cancer, and this seems to be a big difference between high volume centres that see a lot of these scans versus lower volume centres. The lower volume centres with less experienced people just tend to report everything that's positive as cancer, and more experienced people think, what else can it be? And if you're just starting to do PSMA PET CTs, you really do need to upskill. I think this is an area that's evolving with PSMA PET. 10 years ago there were 2 centres in Australia doing PSMA PET. Now there are, I think, more than 80 PET CT centres. Are there 80 PET CT centres? About 100 PET CT centres around Australia where you can get a PSMA PET, often within a few days. So the availability of PSMA PET in Australia is unbelievable, probably some of the best in the world. But with centres just starting up, they often have radiologists or nuclear medicine specialists who really haven't seen many, and now they get their first PSMA PET, and you ought to come to a conference like this and upskill first, but also read some literature and really familiarise yourself with all the little traps. Having said that, it's a very easy test to report because the tumour to background contrast is very good. I think it's easier than bone scanning, CT-MR in many ways, but there are still traps for young players.
Just one little caution, if you don't have the old imaging and you don't know whether it's been there before or not, don't be surprised if your colleagues, your radiology colleagues, might suggest a contrast-enhanced MRI. And one of the reasons why is because both hemangiomas and hydatid's can be quite hazardous to biopsy. So just don't be surprised if they suggest that there is a reason for it.
Yeah, wait for your serology first.
Okay, we might go to the next case, Michael.
Case 8, 63-year-old, PSA is 8. Biopsy shows 4+5 equals 9, grade group 5, so aggressive prostate cancer. The bone scan confirms an osteoblastic rib lesion. We can see it there. It's got linear uptake. I remember this patient. They were on the ProPSMA study, actually. And then the CT showed liver metastases. Sid, are you happy that this patient has metastatic disease?
Well, it certainly looks suspicious on the bone scan, that rib lesion. So I'm not sure about the liver. That's more non-specific, but I don't like the look of that lesion on bone scan.
Yeah. Do you think we need to waste money doing a $1,400 PSMA PET in this patient, or we just do something else?
Well, look, we've got a Gleason 4+5. I think there's I think there's good grounds here.
So management, small volume osseous metastases, Louise. What would you do in this patient with a bone and liver metastases, albeit small volume, but newly diagnosed Gleason score 9?
Yeah. So I think, first of all, I want to know and speak to the radiologist or reviewer in an MDM whether there's any differentials for the liver lesion or whether it is convincing for a
The radiologist said they're very confident that this is metastatic disease. They wouldn't recommend anything else.
Okay. Very helpful radiologist. So I think if there's a liver metastasis, that would be low volume, but they've got visceral disease, so very high risk. So I'd certainly be discussing systemic treatment, and as long as the patient's young and fit, it would be at least, doublet therapy, possibly triplet therapy, depending on their fitness. It sounds like they've got de novo disease with visceral involvement, so they're the cohort that benefits most from the addition of chemo.
As a medical oncologist, with the radiologist being very confident that this is a liver metastasis, do you still want histologic confirmation, or you're happy to proceed with chemotherapy?
I think confirmation is always best. So ideally, I would recommend a PSMA PET scan for this patient. If that's not possible, then probably biopsy the liver lesion, but I think PET scan would be easiest.
Yeah, I think we did do a PSMA PET. Actually, they were in the pro-PSMA trial, so they crossed over as part of the trial to the other arm and had a PSMA PET. James, do you want to tell us the findings?
Yes, so we have a high avid focus in the left. We only have this screenshot. Highly avid focus in the left peripheral zone of the prostate. There are no nodal metastases, and there's absolutely no uptake in the bone. So that right rib and the liver lesions were completely normal on the PSMA PET scan.
Yeah, so I think if you look at the literature, there's this concern about stage migration with PSMA PET CT, where we always pick up more disease. But often, I think this is underestimated, we pick up less disease because of the specificity of PSMA PET. So I think it's fairly clear that these are probably not bone and liver metastases from prostate cancer. And in fact, I think a liver biopsy was performed, and this was a colorectal carcinoma metastasis. And the patient had a very good outcome with colorectal cancer treatment, and also had a radical prostatectomy to treat the Gleason score 9 prostate cancer. So again, denying patients curative intent prostatectomies based on false positive results, both from CT and bone scans, I think is something that's underestimated.
Just a quick question. I know this was the pro-PSMA patient, but then would you have actually, or any of you, done an FDG PET first before sticking a needle in? Does that make a difference, Louise?
I think I would have done a PSMA PET scan first, because that would have been...
And that's it? So it's not PSMA avid. Would we want to do a FDG PET or souping?
Yeah, I think no harm doing an FDG PET.
Got to think about it.
Yeah.
Yeah, I think an FDG PET was done in this case, which showed the colorectal primary.
Yeah, I think the take-home message, as soon as you're thinking another primary's on the cards and you're contemplating a biopsy, why not have a think, why shouldn't I be doing an FDG to try and find the best site to biopsy? I mean, that bone lesion looks suspicious on the bone scans, so we need to get to the bottom of that.
Agreed.
Yeah, it's not always straightforward. I had a case recently where a patient had a 4+3 cancer, PSA 13, only in his 50s, and the PSMA PET showed a completely non-avid prostate, but a very avid retroperitoneal lymph node, which was a bit weird. So they're like, I get an FDG PET, it's one of these mixed clones. The FDG PET, negative prostate, positive lymph node. It's not adding up. So I didn't believe it, so I biopsied it, and sure enough, it was prostate cancer. So even you can get disparity between the primary and the metastasis.
Good.
Yeah, and one of the things we see in the therapy study is a lot of patients with FDG positive, PSMA negative lesions, around 20% of patients in that advanced prostate cancer population. And when we did the therapy study, I think we thought that was due to multiple lines of therapy, development of resistance, PSMA negative clones, tumor heterogeneity. And we don't do a lot of FDG early on like we do very late stage, but some anecdotal experience in the upfront PSMA trial. Louise, this is a trial where we did PSMA and FDG in a newly diagnosed high volume metastatic de novo population. Do you want to comment on that?
Yeah, it was stunning, wasn't it? the number of FDG positive, PSMA negative sites of the disease and the disparity that we really saw. But you know, there's another publication that I agree with. I think there's going to be great publication from upfront to evaluate that. And I hope you've got all of that data. But the other thing is Johan de Bono published a number of years ago where he looked at metastatic, hormone sensitive and metastatic castrate resistant sites, and their level of heterogeneity was actually pretty equal across the two. We thought it was delayed, but it's actually also there early. We have heterogeneous disease.
Yeah, I think we're going to hear a lot more about this heterogeneity at baseline, particularly in these Gleason score 9 aggressive prostate cancers. It's much more common than what we would like to think.
Next case, just a few more to go. 68-year-old with a PSA of 8.8, grade group 1, had brachytherapy in 2012 with a nadir PSA of 1.9, but it's been slowly rising over the years with watchful waiting management, now 31. So can we have a look at the PSMA PET, please, James?
All right, you can see the PSMA PET scan here. There is, if we go down to the pelvis, you can see that, yes, there are multiple seeds of the brachytherapy, the LDR. There's very highly avid uptake in mainly the left peripheral zone, apex to mid, close to base, SUV max of 28. It's really within field. It's not like at the base where you're kind of out of field brachytherapy near the seminal vesicles. We don't see any nodal metastases, so it's really just isolated to the prostate and no distant metastases either on the MIP.
So what would be, Dan or George, what would you like to do?
James, just leave it there, please. Cool. Stop going up and down. You're too fast for me.
Can we change the screen, please?
Oh,
sorry, go back. Yeah.
Yeah. So we see this quite often after LDR. I'm going to let Dan speak in a minute because I know he's got some comments about this case. You often see an area of relative seed paucity, perhaps a poor quality implant all that time ago, and that's where your PSMA is hot. In that data I showed you this morning about my focal retreat program, we've retreated LDR. Failures are my favourite to retreat because, in a way, it's not a true retreat. This is probably an area that was underdosed originally, and I think I'm going to leave it to Dan in a sec, but I would love to see this patient and now cure them with focal SBRT. But I would do that only in my trial where we do, we'll do a biopsy to confirm before we irradiate or re-irradiate because we can cause harm. And they have to have concordant MRI and PSMA PET as part of that trial, and it has to be less than half a lobe because we're trying to limit the dose to the urethra because you can potentially cause fistulae and all sorts of very nasty toxicity here with whole gland retreatment, which I don't believe in. But Dan might want to comment about whether this guy should have been treated in the first place.
Well, that's the issue. I mean, things have changed. It's really interesting to see where we've come from. Remembering LDR brachy came in when there was really no robotics. Open radical prostatectomy was done to a pretty variable standard. PSA had just really been introduced 10 years earlier, and there was suddenly a massive diagnosis of early prostate cancer, all of which we thought was significant and all of which was being treated. And so LDR came as a far less morbid option for most of these men. But it was very strict criteria when it came in. It was for Gleason 3+3, T1, early stage disease, PSA under 10. And now we know you can treat that stuff with crystals. And they'll get the same results. They don't need treatment. What you need to do is to wait until you see how it progresses, and if they do develop clinically significant disease, we treat them. All these men are now on surveillance, and LDR is under-treating this type of condition. I think LDR really, I don't think it's as good a treatment for clinically significant disease. If you're going to treat it, you treat it properly with IMRT and these newer forms of treatment that are even more nuanced with dose painting. And I think LDR, as you say, it's not retreating, it's actually treating it properly.
Great, thank you. We might move on, Michael, to the next...
Could we just change screens, please?
Yep.
Yeah, so this was a review, actually just following up on this case. Out of the patients who had brachytherapy, 26 LDR and 14 with HDR at Peter Mac over almost 20 years. And those who had PSMA PET scans, half of them had prostate-only recurrence. So it is fairly common in this kind of very niche setting. And then 5 in 10 had multi-site or nodal only. Only 2 had metastatic. Just change the slides.
It's a really beautiful infographic.
I was about to say
Yeah,
that.
this is actually from Geneviève Luce from France. She was with us for 1 year and did a very nice review on this. So they had and a lot of them were watched actually, and they had very delayed progression, delayed time to commencing ADT. And you can see 2 examples here. You had some infield, high doses of radiation, 40% recurred within the doses, 35% were in uncovered zones, and then 25% we didn't have any fields to determine.
Okay, now to case 10, Michael.
Yeah, 62-year-old PSA22 radical prostatectomy, another grade group 5. Tumour involving 75% of the prostate. Sounds very nasty, with perineural invasion, extensive extracapular extension, bilateral seminal vesicle invasion. We know that's very bad. And post-operatively PSA 0.19. Let's just say that's at 3 to 4 months. Let's have a look at the PSMA PET scan.
All right, so you can see the pre-op PET scan to the left, the staging one. You have, just zoom it in. There aren't any distant or nodal mets. We'll just go straight to the prostate, but you can see there's very extensive involvement. There's uptake throughout, quite heterogeneous. Near the base, just near the junction of the bladder, there's this more intense uptake of 24. I think it actually does look like prostate cancer. It's not just bladder in this scenario, and then the rest is a little bit milder, SV maxes of around 10 to 11. Very heterogeneous at the periphery, high likelihood of having extracapsular extension, and you see this is a nice example of bilateral seminal vesicle invasion. Quite clearly can pick that up. So we don't see any nodal metastases. So he did have the prostatectomy in between, and you can see in the middle this is the repeat PET scan. There aren't any sites of any focal or suspicious uptake. When you have a closer look, you really just see the bladder. There's nothing in prostatectomy bed, nothing in no nodal recurrence, and no distant recurrence to explain the. All right, you can switch screens, please.
We have an audience vote to make sure that everyone's still alert before lunch.
Definitely had a lag time there. I think they were.
Yeah, I think that's a signal, Ting.
We'll go to rapid fire next.
Did you say the margins were positive, negative? Do you recall?
I don't think you commented.
Positive.
The question with this guy is clearly he's got systemic disease and he's not curable, almost certainly. He's got very high risk disease. He's already got local invasion that's high grade. I feel like he's going to go one of 2 ways, and sometimes waiting a bit longer with another PSA will help guide you as to what's going to happen here, because if he relapses systemically quickly and his next PSA is 1, then you know that local treatment was probably not going to help him. It would give him more toxicity, and he's probably going to benefit with systemic treatment potentially.
One thing I would say on those 2 PSMA PETs is the bladder activity from the excretogen was very low in the first one and very high in the second one, and they possibly also had bladder involvement. So if I was reporting that PET, I would wind right down and actually have a look in the bladder wall to see if you get a difference there, which you can't really see on that.
Yeah, we don't pick it up here. It could repeat, have a Lasix as well. Just try to clear it out, and that's a good point.
All right.
So can we go back a slide? When should patients be considered for salvage radiation? One of the most important things is not to rush in if someone hasn't regained their continence. So first of all, you must make sure that the patient is on their way to continence post-prostatectomy, and that can take some time, especially in a big bad cancer where the surgeon may have gone a bit wider to try and achieve clear margins, and in a cancer where you know you're up against extracapsular extension and seminal vesicle involvement. So don't rush into RT. You can even use ADT if you want as a way of temporising while they improve their pelvic floor, because if you're going to irradiate this guy and he has a small collapsed bladder, you're going to do a hell of a lot more harm than what we usually do is treat with a comfortably full bladder, which is also harder to achieve if you're incontinent. So I think his PSA is now 0.19. I personally would wait a bit longer, somewhat to allow improvement in continence, but also to, as Dan alluded to, if you were to repeat, you still haven't missed the boat. Like I said, the sweet spot for RT is up to 0.5. Why not repeat the PSMA PET? And again, this is a discussion with the patient. If they're super anxious, you might say, we'll just treat now, allay your anxiety. But if they're happy to sit back a little bit, you explain the difficulties in this case. I would probably advise this guy to wait to about 0.4, 0.3 to 0.4, repeat the PSMA PET. Why? Because if there's disease outside the pelvis, then you're wasting your time and you're causing harm.
All right. I think in the interests of time, we're going to move on to some cases looking at the prostate primary. So these are cases of suspected prostate cancer. This is really not something you maybe should be doing in clinical practice today. So take it with a grain of salt, but we think there's an evolving role for this, which we're evaluating in the Primary 2 study. I'm going to leave it to James and Louise, that are really the experts in this, to take us through some cases to get the primary score.
I'll do the cases and then you can discuss what primary score it is. Should we do that?
Right,
Or are we going to
sounds
vote
good.
on primary score?
Yeah, well, there aren't any votes. The videos kind of didn't work out.
And you've only got 6 minutes because we have to.
So I'm hurrying.
We have to get everyone to lunch on time.
No anecdote. So case 11, 53-year-old man referred with a PSA of 8 nanograms per mil. Not had a diagnosis of prostate cancer, but a family history of prostate cancer. PSA density 0.2, MRI, PIRADS 2.
Yeah, Dan, what are your thoughts on that? Like, do you see this often in clinic? Most people go straight to biopsy. You think there's any role for PSMA PET?
This is where we had the discussion about the Primary 2 trial. And we talk about the fact that there's, the MRI will pick up to about 80% of cancers, but not all of them. If he's got a family history and he's only in his 50s, that's a significant PSA and a significant PSA density. I'm very concerned that the MRI has underreported something there. And so standard of care is a template biopsy, but in this case, I would make sure he was well aware of our trial, because a PSMA PET, if there is something there, will almost certainly pick it up.
All right, so if you go to the next one, you have the image right here. So you can see to the right, this patient did have the PSMA PET scan. He was on the Primary 1 trial. The first one led by Louise, 293 patients. Very clear focus. So you have a PIRADS 2. Nothing stands out on the MR. Very intense uptake, SUV max of 12 in the left peripheral zone, transition zone, and on biopsy it was Gleason grade group 3. So it just shows with crystal clear clarity. Primary 2 trial, so really randomizing 1-to-1 ratio, 660 men who have suspected prostate cancer, but an MR that has either PIRADS 2, but a red flag. So for example, in this case, there was family history, high PSA density, so something isn't quite sitting right. Or they can have a PIRADS 3. So standard of care, usually they would go on for that template biopsy, get some cores throughout. And otherwise, to the right, PSMA PET arm, they'll have the PSMA PET. If it's normal, then we can trust that. Like in Dan's presentation this morning, there's a very high NPV, so we can safely avoid it. And if it is abnormal, very high sensitivity of 97%, so we go on to get those biopsies. It's the primary score. We've read and reread these so many times, Louise. Too many. I remember driving to like down to Great Ocean Road, and you kept calling me. Have you done the cases? Have you read the cases?
Do I nag? I don't nag.
It's polite nagging. It's helpful.
Yeah, so you want to go through the scores?
Yeah, I think, yeah, so we're just going to have a chat about the scores. I think we started talking about this when you were down for the preceptorship 2 years ago.
Yep.
So it was 2 years ago, and SUV max is not everything. You know, the more we did interpreted these PET scans, the more we saw these normal patterns, you know, this bilateral uptake. So you have, to the left, you have 3 patterns that we consider normal. Score 1 is there's no uptake in the prostate. It's really just very homogeneous. Nothing stands out. Can confidently say that we think it's normal. Score 2 is split into 2, so you have diffuse transition zone. That's the one in the middle to the left. You can see there's nice uptake in those nice blue and gold colors, so it really stands out. In blue, you can see the peripheral zone really nicely.
The halo. You look for the halo of the peripheral zone.
See a really nice halo, so it's not MR resolution, but you can make it out really nicely with experience. Nothing stands out in that peripheral zone. So we consider these normal. Score 2B, you have a central zone, so base of the prostate, posterior, very symmetrical uptake, and you can have SUV maxes of 6 and 8.
Where the ejaculatory ducts come out is often PSMA avid, and it's symmetrical. Doesn't usually go to involve the posterior margin of the prostate.
Yeah. And to the right, you have those abnormal patterns. So these are the ones going on for biopsy in the primary 2 trial. Score 3, focal uptake in the transition zone. It has to be at least twice background. And actually, I really like this one because there's mild diffuse uptake also.
Twice transition zone background. Yeah. So you take the bright background bit, not the peripheral zone background bit. It's got to be more than twice that. So if it's SUV max 4, you're probably measuring the wrong background. It's got to be usually 6 or higher for a primary score 3.
Yep. Yeah, we've had a lot of these like patchy, little bit of uptake, and finally there's nothing really there. Yeah. Score 4, focal uptake in the peripheral zone, so you can see a nice example to the right in the middle.
And that's independent of intensity. So you have focal activity in the peripheral zone. Sometimes that can be very low-grade activity. Sometimes the focal peripheral zone activity will actually be less intense than what you see in the transition zone. We still call that.
How low do you go? SUV3, is that okay?
Oh yeah, I go down to SUV3. If it's focal, it's present in the peripheral zone, it shouldn't be there. And that includes at the apex. So if you've got an apical lesion as well, in this score system, apex is peripheral zone. Yeah,
so I think those are one of the main teaching points. Then SUV max greater than 12, score 5, we know there's 100% chances of cancer.
But I actually just want to say the reason the primary score actually developed because we're trying to game the system, cheat, really, and the way of cheating, because Pirates cheats, and it's important to be able to cheat when you're a doctor. If you look where most of the cancers arise, more than 70% of them arise in the peripheral zone. Only 20% of cancers arise in the transition zone, but most of the benign activity we see is actually in the transition zone. So it's very helpful to know that. And so what we're doing is we're really gaming the system.
And with that, we're right on time, which is perfect. I would like to thank James Buteau in particular. He's put most of the cases together. It's quite a lot of work to do that. Thank you. And thanks to the entire panel for contributing so many different insights. Maybe just make a point that, we were reviewing the cases with our software. We use MIM. But whatever software you use, one of the problems at the moment is our hospital PACS systems often don't let you fully review PET studies, and you're viewing just a fused series, which is really suboptimal. And to review these scans properly, you need to be able to window the PET image, zoom the PET image. So try to get some software in your hospital so that in the MDT, you can review your PET scans like you would in the clinic. And if you have any questions, we're going to leave them till the break, and people can come up and ask panel members those questions during lunch.